Hi, this is Rosemary, and we're going to be talking about peripheral vascular disease today, and we're going to be looking at the venous side. So our unit objectives are going to be the physiologic factors that affect peripheral blood flow. We're going to look at peripheral circulation. We're going to look at diseases of the arteries and veins, causes, pathologic and physiologic changes, clinical manifestations, and management. We're going to do management of a venous thrombosis, venous insufficiency, and using the nursing process we're going to do in class. So the first one we want to look at is a thrombophlebitis. This is a blood clot that forms on the venous walls. When we look at the venous system, it is a low pressure system in comparison with arterial. Stimulation by the sympathetic nervous system causes the veins to contract. Skeletal muscle contractions and pressure changes in the abdomen move the blood from the periphery to the central system. Venous thrombi are more common than arterial thrombi because of the lower pressures and the lower blood flow. The blood becomes stagnant. What we'll see is an inflammation of the blood wall or the vessel wall. It can be caused by a trauma, abdominal or thoracic surgery, orthopedic procedures, pregnancy. And when we have that vessel trauma, we stimulate the clotting cascade, the platelets aggregate at the site, the fibrin mesh begins to build, and the red blood cells are trapped in the fibrin meshwork. The inflammatory response is going to be triggered. It's going to cause a tenderness, swelling, and erythema in the area of the thrombus. Now remember, a blood clot takes about 7 days to break down. So when we look at patients with DVTs, we're not looking at breaking it up and causing it we're not looking at using the fibrinolytics to break it up unless it's completely occluding that artery. We're going to let nature take its course and slowly dissolve that, but what we want to do is we want to prevent any further clotting. So when we look at a DVT, we're going to see a red hot swollen leg. We're going to be assessing for we may be able to feel a palpable cord. What happens with DVTs, and like I said, we just let them dissolve, but a piece of that clot can break off, and now we have an emboli, and it can go to the heart, it can go to the lungs, it can go to the brain, it can go to the kidneys, it can go just about anywhere. So that could be some of the complications. We also we've looked at superficial venous thrombosis, and one of the things, can be caused by venous catheters and venous infusions. Other risk factors include varicose veins, pregnancy. What we're going to see, again, when we talked about this before, is we see a redness and we see swelling and localized pain, and we can actually feel the cord-like structure of that vein under the skin. When we're looking at management of DVT, our diagnostic test, we want to do an ultrasound to see where exactly that clot is. We can also do a venous phlegmography, and this is a test that measures the change of blood flow in the veins. We can do a contrast phlegmography, where they actually inject a dye and map out the veins. Any one of these is going to tell us that we have a clot. So for prophylaxis, we're going to, for our patients who are immobile or who have a decrease in their mobility, they're going to be on a fractionated heparin or a heparin product. Our patients that are going to go home, we want to put them on a fractionated heparin or a heparin product, and then we want to treat it with warfarin. And your patient that's on warfarin, they're going to need to be monitored, and they're going to need to be on warfarin for about 6 months. We want to teach prevention of DVT, so If they're on bed rest, we want their legs elevated 15 to 20 degrees. We want TED hose or the pneumatic compression devices. We want early mobilization. And the other thing for treatment is to have them do their ankle exercises, their dorsiflexion exercises, to prevent blood clots by causing contraction of the skeletal muscle. The treatments, we can do surgery, we can do a venous thrombectomy depending on how large the clot is and where it is, where they actually go in. We talked about this when we talked about cardiac catheterization, but they actually go in and they do like a roto-rooter and they suck out the blood clot. This is going to be the same nursing interventions as when we did our cardiac cath. Our patients can have a filter in the vena cava. We talked about this when we talked about pulmonary, where they actually put a filter in the inferior vena cava right below the renal veins, because of course we don't want any clots going into the renal veins and causing acute kidney disease or acute kidney failure. So we want that filter there. And again, can be done through a cardiac catheterization. The other thing we can do is a ligation and division of the vein, where it joins the femoral vein to prevent clot extension and going into the deep venous system. This we'll talk a little bit more about this when we talk about venous ligations. For our patients, we want to prevent it. We want to position with the feet elevated, the knees slightly bent. We want the early ambulation. We want to teach them ankle flexion and extension exercises to, again, help those muscles to contract. We want the TED hose on or the pneumatic stockings, and we want to frequently assess our IV site. Another problem that we can see with our venous system is varicose veins. These are very irregular, tortuous veins with incompetent valves. And we see, excuse me, we see this, first of all, varicose veins can occur anywhere. We see varicose veins in the GI tract, and we call them esophageal varices. We see them in the rectum, and we call these hemorrhoids. Usually affects the veins of the lower extremities, the long and short saphenous vein. Our risk factors are going to be because we're getting older. It depends on our occupation. Prolonged standing or prolonged force of gravity, lack of leg exercise, long periods of standing, puts our clients at risk. What happens is with this is we see incompetent valves, and so we see an engorgement of the blood in those vessels. The symptoms, our patients may complain of severe aching leg pain, leg fatigue, leg heaviness. Complications can be venous insufficiency, which we'll talk about in a bit, or we can develop DVTs. The diagnostic test, we're going to do a history and physical to see what our patients, if they have any of those risk factors. We're going to do a Doppler ultrasound looking for any blood clots. We can do a Trendelenburg test. This is where our patient is strapped to a table, and when we do put them in Trendelenburg or lower their head and raise their feet, we'll see these veins flatten out. And then when we put them the other way with their head up and their feet down, we'll see again the engorgement in those legs. Treatment again is compression stockings. These are more than just the TED hose. These are specially measured and applied, and they start with a compression of about 20 millimeters of mercury at the foot or at the toes, and then the compression increases as it goes upward to about 70 or 80 millimeters of mercury at the lower or at the thigh. Regular daily walking is going to help move that blood, help decrease the size of those varicosities. And what we're going to maybe need to do is surgery or sclerotherapy. So with surgery, a venous ligation, this is stripping of the greater and lesser saphenous veins. They may even do a bypass of this. What we're going to be watching for, of course, is peripheral circulation. We're going to be applying pressure bandages for 6 weeks. We're going to be elevating the lower extremities to minimize edema. We're going to do gradually increasing ambulation. And we're going to have them avoid sitting and standing. Again, we don't want a lot of pressure on those while it's healing. Another one of our diseases that we can see is chronic venous insufficiency. This is inadequate venous return. Most common cause is varicose veins. It can be leg trauma. We can see this after a DVT. The large vein may remain occluded, increasing the pressure in the other veins of the extremity. What we're going to see is with chronic venous insufficiency, there's a damage to the valve leaflets. And so with this, what we're going to see is this line of demarcation. So you can see right here, we have a line of demarcation where we have blood engorgement of the lower veins, and then where the valves are competent, we're going to see nice pink. The patient may complain of lower extremity edema, thin shiny skin. They may have this brownish discoloration down here. They may see some weeping dermatitis. They're going to have this thick fibrous subcutaneous tissue and recurrent ulcerations. So again, we have incompetent blood flow, and we're going to see this venous engorgement. With our patients, one of the big complications with venous insufficiency is a venous ulcer. And we talked about arterial ulcers where the location is on the toes. This is going to be over the medial or anterior ankle. We're going to see with our arterial, the toes, or the ulcer is going to be pale, or it's going to be deep, where these are more superficial and pink. The skin is going to have some brown discoloration, and with our arterial, we're going to have pallor on elevation and rubor on dependency. Our skin temperature is going to be normal. We're going to see edema. Typically, they have some mild pain. What we don't see any gangrene, and their pulses will be normal, as opposed to our arterial, where we're going to have absent pulses, gangrene, pain, claudication, and typically with our arterial ulcers, we do not see any edema. With chronic venous insufficiency, we want to avoid prolonged standing or sitting. And this is that graduated compression hosiery. This is where it starts at about 10 to 20 millimeters of mercury, and it goes upward. Again, we want that blood flow not to congest in the periphery, but to move on forward. And they may need frequent elevation of their legs, bed rest during acute periods, wet to dry dressings if they have stasis ulcers, and we're going to see they may need surgery. And that's the end. Thanks and have a great day.